بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أنا سارة فراج. خلال الساعة القادمة بحاول أشرح Infective Endocarditis. حاولت أجيب صور عشان يسهل الشرح ويكون أوضح، وعشان نوصل المعلومة بشكل كامل استخدمت عدة مصادر منها أنبوس ومدد وتيم. Overview of the objectives. We are going to talk about Infective Endocarditis definition, the pathophysiology of endocarditis, the risk factors, the signs and symptoms, prophylaxis, and when it is recommended, investigation, and diagnostic criteria, or complication of treatment of infective endocarditis. بداية, what is infective endocarditis? Infective endocarditis, it is infection of endocardial surface of the heart, which may include one or more of the heart valves, native or prosthetic, cardiac tendinae, and septal defect with more endocardium. So the layers of the heart internally start with endocardium, then a myocardium, then visceral layer of serous precardium, then precardial cavity, then the parietal layer of precardium. كتذكير, the right side of the heart have the tricuspid valve, pulmonary valve. Left side of the heart there is the mitral valve والaortic valve. So as I explained, infective endocarditis might develop on a ventricle or a septal defect. It could be ventricle septal defect or atrial septal defect. The normal heart is on the left side. You can see it here. There is a ventricle septal defect where there is defect in the septum between the two ventricles, and if it is between the two atrium, it's an atrial septal defect. Infective endocarditis develops most commonly on mitral valve, then on aortic valve, then tricuspid valve, and rarely on pulmonary valve. While next we're going to talk about the pathophysiology, and you should really understand why it is more commonly in the valves. But it also can affect a moral endocardium. What do I mean by moral endocardium? It is the medical term for the lining of the heart chamber's wall. Now talking about the pathophysiology of infective endocarditis, it is a net result of a complex interaction between bloodstream pathogen, a matrix molecule, and platelets at the site of endocardial cell. What is a matrix molecules? They are the extracellular matrix that helps the cells forming a structural, mechanical structure or strength to tissue and organs. First, we need to have endothelial damage caused usually by turbulent blood flow. زي ما انتم شايفين بالصورة كيف turbulent blood flow look like. This turbulent blood flow usually produced by either congenital or acquired heart disease. It could be from a high to low pressure chambers زي ما في ال ventricle septal defect. The ventricles in the left side of the heart has a high pressure in compared to the right side. So the blood will go from the left side of the heart to the right side of the heart with a turbulent blood flow causing injuries to the endothelium. Or it could be because of a high velocity flow across a narrow orifice. You could see here in mitral valve stenosis where the valve is not opening very well. The blood flow will be in high velocity through a narrow orifice, which will cause a trauma to endothelium. Exposed subendothelial layer will attract platelets and it will form a non-bacterial thrombotic endocarditis. The forming of a non-bacterial thrombotic endocarditis is because of deposition of platelets and fibrin. And after that, there would be, if there was an invasion of bloodstream by microbial species with a pathogenic potential to canalize at the site, which is endocardium, It will result in the proliferation of bacteria within non-bacterial thrombotic endocarditis, forming vegetation, which is the hallmark of infective endocarditis. Vegetation is an abnormal growth. This is what vegetation look like. You could see here. These are big vegetation on a valve that extend through chordae tendons. This is what a bacterial colonization might look like. So, what is the source of bacteremia in infective endocarditis? A trauma to mucosal surface heavily populated with indigenous microflora such as gingivia around the teeth, or an oropharynx, or GI tract, or urethra and vagina. This will release these many microbial species into the bloodstream, which will lead to a transient bacteremia. If the species or the organism that invade the bloodstream has the potential to colonize at the site of non-bacterial thrombotic endocarditis, this will lead to infective endocarditis. Now, risk factor for infective endocarditis would be patient factors like age, more than 6 years, male, IV drug users. It would be mainly Staph aureus because Staph aureus is the normal flora of the skin. And introducing a needle through the skin into venous circulation, it will lead to invasion of bloodstream with Staph aureus. Burdentation, it would be mainly a strep viridine, which is the normal flora of the mouth. And then we have medical conditions. I like to divide them to cardiac medical condition and non-cardiac medical conditions. It's a risk factor to have a structural heart disease, liver heart disease, such as rheumatic heart disease, aortic stenosis, degenerative valvular disease, congenital heart disease, prosthetic heart disease, previous endocarditis, cardiac implantable electronic device. For non-cardiac medical condition, intravascular device, indwelling catheters, chronic hemodialysis. In chronic hemodialysis, because it's required frequent use of catheter or insertion of needles to access the bloodstream. So it's actually presenting the normal flora of the skin or organism outside the body to bloodstream. HIV infection where there is a decreased immunity. So for the cardiac medical conditions, having a valvular heart disease, it might facilitate endothelial damage, such as high velocity flow through a small or narrowed orifice. Now for determining the risk of infective endocarditis to decide to give prophylaxis or not. It's depend on two factors. Both of them must be there to receive prophylaxis. First of all, the type of procedure to be done, then present or absent of cardiac condition. The type of procedure to be done has to be dental procedure that require manipulation of gingival or preapical region of teeth or perforation of oral mucosa. And then the present of cardiac condition, it must be one of these four conditions. First, prosthetic cardiac valve, including a transcatheter valve or prosthetic material used for cardiac valve repair. What do they mean by transcatheter? It's a valve replacement through bloodstream, blood vessels. You could see it here. The valve has been replaced not with open surgery, no, it's with a transcatheter valve replacement. These are examples of prosthetic valves. There is a mechanical and tissue. Then second, to have a history of previous endocarditis. Third, to have congenital heart disease such as ventricular septal defect, patent ductus arteriosus, Q articulation of aorta, complex cyanotic disease. A patent ductus arteriosus, it is an abnormal connection between the pulmonary artery and the aorta in the heart. You could see it here. And the coarcutation of the aorta is a congenital narrowing of a short section of the aorta. For the complex cyanotic disease, it's a cyanotic congenital heart defect. They are congenital cardiac malformation that commonly affect the atrial wall. They are categorized by right to left shunt, which lead to the right side of the heart will contain deoxygenated blood. If the shunt was from right to left, the deoxygenated blood will enter the systemic circulation, resulting in hypoxemia manifested clinically as cyanosis. They refer to them as blue babies. It's congenital, that's why they're babies. One of these diseases is a transposition of great vessels, which have a beta inductus arteriosus and atrial septal defect. Fourth is a cardiac transplant with a valve regurgitation due to structurally abnormal valve. So I really want to explain what is valve regurgitation is. In normal valve, for example, mitral valve, it will be opened if the left atrium contracts, so the blood will flow from the left atrium to the left ventricle. And it will be closed when the ventricle is contracted. So all the flow from the left or the blood from the left ventricle will go through the aortic valve. But in the case of valve regurgitation, the valve is weak, so it cannot close very well. While contraction of the left ventricle, there would be a backflow. So having one of these cardiac condition and the procedure that must be done is a dental procedure, an infective endocarditis prophylaxis is recommended. It's recommended to have amoxicillin or ampicillin. If the patient is allergic to penicillin, clindamycin is a choice. And then there is the classification of infective endocarditis. Depending on the nature of the valve, there is native valve, congenital, or prosthetic. The gene نقول the valve is prosthetic. It could be early or late. If the presentation was within 1 year after the prosthetic valve or after the surgery, it's an early prosthetic valve. If it's after 1 year, it's a late prosthetic valve endocarditis. And then depending on the onset and progression, there is acute, subacute, and chronic. Acute symptoms up to 6 weeks. If the symptoms from 6 to 3 months, it's subacute. Chronic would be having the symptoms for more than 3 months. And there is the classification depending on acquisition of the infection: nosocomial, community, or IV drug abuse. Question here: what carry more risk of infective endocarditis, native or prosthetic? It would be prosthetic because it's a metal, so it has no blood supply, no antibiotics can reach it. الحين نقارن بين acute versus subacute. For acute presentation, it's usually or more commonly the causative organism would be Staph aureus. أبيكم تربطون Staph aureus to be aggressive organism. So because Staph aureus is aggressive, it will affect normal heart valve, which usually tricuspid. Staph aureus is very aggressive. The prognosis of this presentation is, if untreated, it would be fatal in less than 6 weeks. Then for subacute presentation, the most commonly causative organism would be either Streptococcus viridine or Bovius. They affect previous damage heart valve, so they are less aggressive in بالمقارنة بستاف aureus, which affect a normal heart valve. If untreated, the Streptococcus viridine or Bovius, it would take much longer than 6 weeks to cause death. So let's have an overview of causative organisms. First, Staph aureus. They will lead to aggressive acute infective endocarditis, high chance of metastatic infection, and valvular destruction. What do they mean by valvular destruction? It is the valvular regurgitation. Commonly among IV drug users, most commonly affecting the right heart tricuspid. So they are more commonly among IV drug users because they are a normal flora of the skin. Most commonly affecting the right high tricuspid. نقدر نربطه بأن ال IV drug users they will insert needle through the skin, so this is the normal flora of the skin, Staph aureus, into the venous circulation, having the organism facing the first valve they're facing when entering the right side of the heart is tricuspid valve. هو بس للربط. Then we have Streptococcus viridine, most common cause of subacute infective endocarditis, especially in pre-damaged native valves, mainly mitral valve. Common cause of infective endocarditis following a dental procedure. We have third coagulase negative staph, for example, staph epidermidis. So coagulase positive would be staph aureus, and coagulase negative would be staph epidermidis. They're more commonly linked to foreign body infection. What do they mean by foreign body? زي catheters, more commonly with nosocomial infection. Then we have Streptogaiolethicus, previously known as Streptovovius. It's a GI flora associated with polyps and colon cancer. So if the patient presented with infective endocarditis and the blood culture shows Streptoglycolyticus, you should do colonoscopy. It will lead to subacute endocarditis, highly sensitive to penicillin. So, subacute endocarditis, it might be caused by Streptococcus, or most commonly caused by Streptococcus viridine and Bovius. Lastly, we have endococci. They are GI flora associated with UTI. What are the most common causative organisms? For a native valve, infective endocarditis most commonly would be because of Streptococcus viridine. Second, because of coagulase positive Staph aureus or Staph epidermidis. IV drug users most commonly Staph aureus. Then it might be because of streptococci ولا endococci, gram negative bacilli والفانجاي. Then we have prosthetic valve. زي ما شرحت يقسمونها قسمين, early onset and late onset. If the presentation was within 1 year after the surgery, it most commonly because of a staph epidermidis or staph aureus. If it's late after 1 year of the surgery, it might be because, or most commonly because, of Streptococcus viridine. So if a patient with a history of valvular heart disease and history of dental procedure have the manifestation or present with endocarditis, it would be more commonly because of Streptococcus viridine. If an IV drug user presented with endocarditis, it's more commonly because of Staphylococcus aureus. If the patient who has done prosthetic valvular surgery presented with endocarditis later, if the if he presented within the first year, it most likely is Staphylococcus epidermidis or aureus. If the presentation after 1 year of the surgery is Streptococcus viridine, more commonly. A patient has a colorectal cancer and presented with endocarditis, it is because Streptococcus bovius. Why is that? Because bovius is GI trach normal flora. If the patient presented with endocarditis but all blood cultures are negative, it's more likely because of HESEC group. What are these? HESEC are fastidious gram-negative bacilli, positive blood culture after 5 days of incubation and might take longer. They would have a large vegetation. Culture negative endocarditis usually is caused by prior administration of antibiotics before obtaining blood culture or by infection with fungi or Hicks species. Coxella also a gram-negative pathogen responsible for culture-negative endocarditis. So for the signs and symptoms, there will be two courses: indolent course, explosive course. Indolent course would be fever, malaise, fatigue, night sweats, anorexia, and weight loss. Explosive course would be congestive heart failure, new or changing murmur with severe systemic sepsis. For the cardiac failure, patient might present with dyspnea and lower limb edema. بعدين عندنا الاميونولوجيكال features بسبب الفورميشن of immune complex اللي هي binding of antigens مع antibodies يختلفون في الأحجام. Large in size would be removed by macrophages normally. Small size, they might deposit in small blood vessels, initiating the complementary system, which will activate the immune system, resulting in immunological features. One of these features is Osler nodes. They are painful nodules on beds of the fingers and toes caused by immune complex deposition. And then we have Roth spots, which are retinal hemorrhage with a white or pale centers. The white center which would reflect embolization and lose of blood supply. And then we have glomerulonephritis بسبب immune complex deposition in kidneys, leading to inflammation of the kidneys, proliferation of glomerular cells, leukocyte infiltration, classically manifested with nephrotic syndrome having glomerulonephritis. And then there might be positive rheumatoid factor. تقدرون تشوفون الأوزلر nodes في ال first digit و second digit here and here, and there are spots. For the Osler nodes عشان تذكرون إنها painful, for the first letter which is O, ouch. So O Osler, ouch, they're painful. And then we have vascular and septic features because of the vegetation detached from the heart or from the site of infective endocarditis traveling into the circulation. We have splinter hemorrhage, which is a hemorrhage in the nail beds, and we have Janway lesions, which is small, non-tender, non-painful erythematous mucosa on the blame and sole. They are non-palpable skin lesion from vulvar vegetation. And we have subconjunctival hemorrhage, mycotic aneurysm, which is an infection of Fizzle's wall, hematuria leading to anemia, and septic arthritis. You could see here splintic hemorrhage and here Janway lesions. So Osler nodes, they are painful. Janway lesion, they are not painful or non-tender. We have here subconjunctival hemorrhage and here mycotic aneurysm. This is an imaging for mycotic aneurysm, which is considered a vascular and septic feature of infective endocarditis. Here we have septic arthritis. There is other signs and symptoms, including splenomegaly. It could be because of splenic artery occlusion or spleen abscess. And then we have petechia, which is a small red non-plunge macular lesion caused by intradermal capillary bleedings. This is what petechia look like. Other symptoms might include a neurological manifestation, like seizure due to septic emboli, stroke, hemorrhage, meningitis, encephalitis, or abscess in the brain. For clinical suspicion investigation, there is blood culture, which is best initial and key diagnostic investigation, and it should be before initiation or initiating antibiotic therapy. بيكون at least 3 sets of samples taken from different vein puncture sites over 24 hours under aseptic techniques. What do they mean by vein puncture? It's from veins, so venous circulation. So if blood culture was negative, it cannot rule out endocarditis. It could be false negative due to antibiotic therapy before blood culture sampling, or because of Fastidious bacteria, which is الهيسك group, if you remember. And it could be because of Coxella. So we should consider serological tests. Then we have CBC. There would be reduced hemoglobin due to anemia, increased white blood cells, and increased or reduced platelets. Then inflammatory markers, there would be increased erythrocyte sedimentation rate and C-reactive protein. So C-reactive protein reduce in response to therapy, increase with relapse. So it's helpful in monitoring therapy. Then we should do a renal function test. There would be increased urea and creatinine due to glomerulonephritis. Urine test or analysis, there would be proteinuria and hematuria due to glomerulonephritis too. ECG, there might be PR prolongation or heart block associated with aortic root abscess. So aortic root abscess is a complication of infective endocarditis. There might be chest X-ray findings, pulmonary edema in left side disease, and pulmonary emboli or abscess in right side disease. حاب أوضح ليه pulmonary edema associated with left side disease و pulmonary emboli or abscess in right side disease. So for right side disease, the vegetation detach, it will travel to the pulmonary circulation, which will lead to pulmonary emboli and abscess. But if the disease was on the right side, infective endocarditis might lead to valvular destruction, which is regurgitation, high blood pressure or backward of blood flow, leading to increased pressure on the left side of the heart. There would be a backward pressure increase, leading to pulmonary edema. And then lastly, we have echocardiograph. It's a cornerstone of diagnosis. First line is a transthoracic echocardiograph. It might detect vegetation, valvular dysfunction, ventricle dysfunction, and abscess. And it's non-invasive. It's the first line, but it cannot rule out infective endocarditis. You could see here تقدرون تشوفون هنا كيف شكل transthoracic عبر الchest. النوع الثاني عبارة عن transesophageal echocardiograph. It's useful in suspected aortic root abscess and essential in prostatic valve endocarditis and endocardial device or complication. It's invasive, it's second line, it can rule out. So بس نتذكر مع بعض. Blood culture cannot rule out. Negative blood culture cannot rule out infective endocarditis. Transthoracic echocardiograph نفس الشيء. You cannot rule out infective endocarditis using transthoracic echocardiograph. But transesophageal echocardiograph, it can. So إذا كان البيشنت high suspicions, you did a transthoracic echocardiograph, nothing, you might go with transesophageal echocardiograph. So now for DO criteria, it's used for infective endocarditis. بيكون في 3 احتمالات. يا definitive infective endocarditis, possible infective endocarditis, and rejected infective endocarditis. There is major criteria and minor criteria. Major criteria عبارة عن نقطتين فقط. Number 1 is positive blood culture. Number 2 is endocardial involvement. كيف ممكن نقول blood culture is positive if there is 2 separate culture showing growth of a typical organism like strep, staph, الهيسك, or a persistent positive blood culture. كيف ممكن نقرر إن البلد culture are persistent positive blood culture إذا كان في أكثر من 2 positive blood culture of samples مأخوذة بينهم 12 ساعة. إذا كان في 2 أو more أو أكثر positive blood culture بينهم 12 ساعة, this is a persistent positive culture. أو 3 all of 3 is positive blood culture بين الأولى والأخيرة ساعة كاملة, أكثر من ساعة, أقل شيء ساعة. It's considered persistent positive blood culture, and you could get the point of positive blood culture for a major criteria. الخيار الثالث single positive culture for Coxella. Coxella It is responsible for a negative culture فواحدة تكفي إذا كانت positive, or a phase when AGG antibody titer more than 1 to 800. Coxella is responsible for Q fever. Q fever presentation might include endocarditis. يستخدمون ال AGG titer as a diagnostic criteria في Q fever. It has two phases, phase 1 and 2. عشان كده كتبوا هنا phase 1 AGG antibody titer. It's just a criteria for Coxella. You need just phase 1 AGG antibody to be more than 1 to 800 to have a positive blood culture buoyant for major criteria. Then we have endocardial involvement. كيف ممكن نقرر that there is endocardial involvement؟ في 4 حالات. Positive echocardiograph finding of vegetation, abscess, side aneurysm, endocardial fistula, valvular perforation, or aneurysm, or new partial dehiscence of prostatic valve. طيب وش المقصود dehiscence؟ إذا كان في جرح edge of the wound is approximated تقربوا من بعض كان بس sutures or normally healed صار في separation after that هاي يسمونها dehiscence. If there is a new partial dehiscence of prostatic valve في الechocardiogram, it's a point for endocardial involvement. You could see here vegetation in echocardiogram, and you could see here pseudoaneurysm. هنا صورة أوضح. هنا fistula والaneurysm. بعدين بنعتبر إن في endocardial involvement إذا كان في abnormal activity around the site of prostatic valve implantation detected by fluidoxoglucose PET CT scan. إذا كان الفالف implanted for more than 3 months, or radiolabel leukocyte مع CBE CT. أول CT عبارة عن اللي هو BET CT. It's a posturone immersion tomograph CT. They use radioactive materials to evaluate organs and tissue function. It can identify a change at cellular level. So CT it will بناخذ صورة للstructure بس مع البسترون emission tomograph we can evaluate the organ and tissue function. اختصار الفلودو oxyglucose it's FFDG. This is the radioactive materials that have been used. Radiolabeled leukocytes it is a single photon emission بيلقط لي الجاما rays. It will detect metabolic abnormalities. There would be endocardial involvement if there is definitive paravalvular lesion by cardiac CT or new valvular regurgitation. Stenosis is not there, بس في valvular regurgitation is considered endocardial involvement. في شي حابة أوضحه هنا. Major criteria بس ممكن يكون عندك 2 points لها. بنحسبها عشان نشوف هي definitive or possible infective endocarditis or rejected. Then we have هنا الصورة بس توضيحية للregurgitation. Minor criteria if the fever was more than 38 degrees or there is an echo finding, any finding not involved in the major criteria, say calcification. You could see here calcification and echo. And 1 point if there is a vascular phenomena like major atrial emboli, septal pulmonary infarct, infectious myocardial aneurysm, intracardial hemorrhage, conjunctival hemorrhage, Janeway lesions. So it doesn't matter if the patient have 2 of these. For the criteria, it will be considered 1 for vascular phenomena. Evidence from microbiology, positive blood culture, but does not meet the major criteria, or serological evidence for active infection of organism consistent with infective endocarditis. ونقطة ل risk factors such as heart disease or heart condition, valvular heart disease, prostatic valve, previous infective endocarditis, or IV drug users. Immunological phenomena like glomerulonephritis, ozone nodes, rough spots, and rheumatoid factor. Then for Duke criteria نجمع النقاط بتكون يا definitive infective endocarditis or possible or rejective infective endocarditis. For definitive infective endocarditis, if the patient have there is a clinical criteria and pathological criteria. For clinical criteria, if the patient have two major criteria أو إذا كان عنده one major or three minor or five minor. For the pathological criteria, if a microorganism or pathological lesion was demonstrated by culture and histology and vegetation. So it's a definitive if they culture a vegetation. If it's a blood culture positive, it would be just a major criteria, 1 point. Or a vegetation that has been embolized or intracardial abscess. So if there is intracardial abscess, it's a definitive infective endocarditis. For possible infective endocarditis, clinical criteria would be with patient with one major and one minor, or just three minors. في الأخير عندنا rejected infective endocarditis if the clinical criteria didn't meet the definitive or possible clinical criteria, or if there was the presence of firm alternative diagnosis of the manifestation of infective endocarditis. إذا كان في differential diagnosis غير infective endocarditis, it might be rejected, say non-bacterial thrombotic endocarditis. Resolution of manifestation of infective endocarditis with antibiotic therapy for less than 4 days or equal to 4 days. بس عشان نقدر نربط infective endocarditis أقوى من إنها ممكن تختفي مع المضادات في مدة أقل من 4 أيام أو يساوي 4 أيام. If there is no pathological evidence of infective endocarditis as surgery or autopsy after antibiotic therapy for 4 days or less. Then we have the complication of infective endocarditis. Complication might be due to vegetation and embolism, or local spread of infection, and metastatic spread of infection, or formation of immune complex, leading to complication of infective endocarditis. هذه تقسيماتها، مش حابة أعبى على كل واحدة منها. So let's start with complication because of embolism. Traveled, for example, from left side of the heart to the brain, resulting in neurological manifestation because of a stroke. Due to major embolism to middle cerebral artery, or intracranial hemorrhage بسبب ruptured myocardic aneurysm, or hemorrhage transformation of stroke. There might be myocardial infarction or pulmonary embolism, ischemic limb, mesenteric ischemia, splendic or renal infarction, or digital infarct. Local spread, there might be congestive heart failure caused by extensive failure destruction, or ruptured cardiac tendinae, or fistula or valvular obstruction, myocarditis, coronary artery embolism, myocardial infarction, or myocardial abscess. You could see here a rupture of a cardiac tendinae. Here is valvular obstruction, which is stenosis. بس شرح بسيط للvalve stenosis. الvalve بيكون very thick that it cannot open well, فبيصير فيه الflow decrease. There might be a paravalvular abscess, which is most common in aortic valve, IV drug users, Staph aureus infection. IV block or conduction disorder because of myocardial abscess, or precarditis. So precardium is a layer covering the heart. If the infection goes to the precardium, it will lead to precarditis, leading to inflammation. Then we have metastatic spread. For right side vegetation, there will be lung abscess, biothorax, bioneumothorax. Biothorax refers to the presence of inflammatory fluid or pus within the chest cavity. Bioneumothorax is a pleural collection of pus and gas. So this is the right side of the heart. If the vegetation detach, it will travel to the pulmonary circulation, leading to lung abscess, biothorax, and pneumothorax. If the disease was left-sided, the vegetation would travel to the rest of the body, leading to pyogenic meningitis if it's reached the brain, splendic abscess, or pyelonephritis. And there could be osteomyelitis, which is inflammation and swelling that occurs in the bones. There might be metastatic abscess and septic arthritis. خلصنا الcomplication of infective endocarditis. بالنسبة للفيفر تختفي within 5 to 7 days. If there is a persistence of fever, it will indicate either abscess or infective indwelling catheters or device, septic embolization, an extracardial site of infection, inadequate antibiotic treatment of resistant organism, an adverse reaction to antibiotic therapy itself. Now for the management of infective endocarditis, the medical therapy and surgical. For medical, it would be antibiotics. The empirical therapy should start as soon as possible. Empirical therapy goal is to provide broad spectrum coverage. But there is a principle of medical therapy or antibiotic therapy that you need to do blood culture first, then start treatment. Blood culture first to decrease a false negative result of blood culture. For acute onset, because it's aggressive, you should start the treatment as soon as possible, and it should be within 3 hours. But as I said, blood culture first. Antibiotics for acute onset would be vancomycin and gentamicin. For subacute onset, the treatment should be started within 3 days. Blood culture first. Antibiotics would be amoxicillin with or without gentamicin. For prosthetic valve infective endocarditis, antibiotics would be vancomycin, gentamicin, and rifampicin. A beacon to the Quran, gentamicin and rifampicin with the prosthetic valve. The antibiotic therapy is divided into empirical therapy, and after the culture results are available, you would change the therapy according to the results. You should treat vegetation with high dose IV bactericidal antibiotics for prolonged duration. For a native valve, the duration of treatment would be from 2 to 4 weeks, and prosthetic valve would be more longer duration from 6 to 8 weeks. إذا كان الأورجانيزم عبارة عن Staphylococcus, which is penicillin susceptible Staph aureus, on a native valve, treatment would be flucloxacillin or nifacillin or oxacillin for 4 weeks. But if the organism was resistant Staph aureus or the patient is allergic to penicillin, the treatment would be vancomycin for 4 to 6 weeks. إذا كان الvalve prosthetic, you would just add gentamicin and rifampicin. If the organism was streptoviridine or bovius and penicillin susceptible, the first choice would be IV ceftriaxone once daily for 4 weeks, or ceftriaxone orally 2 grams for 2 weeks, followed by oral amoxicillin for the next 2 weeks. So in total would be 4 weeks, or IV penicillin G or IV amoxicillin for 4 weeks. But if the organism were penicillin resistant, would be ceftriaxone with gentamicin. So there would be combination of antibiotics to decrease a chance of developing another resistant against cephalosporin. If the patient is penicillin allergic, you would use vancomycin with gentamicin. And there would be indication for cardiac surgery in an infective endocarditis if there is heart failure due to valvular damage, dehiscent endocardial fistula, prosthetic dysfunction, or failure of antibiotics therapy because of persistent infection, canned bacteremia or fever, lasting more than 4 to 7 days after starting antibiotics. Or if there is large or persistent vegetation on the left side of the heart valve with an echo appearance suggesting a high chance of recurrent emboli. So you really want to prevent the complication of embolism. Infective endocarditis complicated by heart block, annual abscess, destructive perforating lesion. Patient with fungal endocarditis, always the treatment would be cardiac surgery. And prosthetic valve infective endocarditis caused by fungi or high resistant organism. That's all. Thank you for listening.